So thank you for inviting me, and thank you to the amazing truth here that have me talking to you in 3 dimensions. It's very, very cool. Although I do love that view from that campus out over the bay, so missing that. But everything is kind of different, kind of neat. Anyway, you were kind enough to invite me to your conference, and you were trying to draw from me my experience using ME/CFS. It's a population that I've learned so much of the management in these complex illnesses, using patients that have sort of many diagnoses all at once. So I thought I'd just approach the broad question of fatigue. Fatigue is a really tough question to approach because there are so many different reasons to have fatigue. All right, we're starting over. So anyway, I was saying I'm going to approach the big, broad concept of fatigue and what causes fatigue. And just right from the beginning, you often heard people say that the Eskimos have 20 different words for the word snow. Well, fatigue is like that. What do you mean by fatigue? You know, there's different types of fatigue. There's physical fatigue, there's mental fatigue, there's emotional fatigue. And there are concepts around fatigue. There's the idea that fatigue is a cellular energy exhaustion. That's one possibility. Sometimes fatigue is coming from signals in the brain that signal fatigue, 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 no rest. And that's another kind of fatigue. Sometimes it's imbalance of all the systems that regulate your body and its energy system, like the thyroid hormone, for instance. It's very important for energy. And yet it's in a complex network of other hormones, and it needs to have a nice balance. And then there's fatigue. We've all experienced this, the emotional safety valve after you've sort of had an emotional meltdown, and afterwards you're not energized, right? You feel like you need to go to bed for that. So there's different weird triggers and reasons for having fatigue. I've worked in ME/CFS now since the 80s, a long time, and I've learned an awful lot. And most of what I've learned from my patients. I am a scientist and a clinician, and we do a lot of studies. But I will say, just using your 2 ears and understanding what your patients are telling you is often the most important part of understanding what's wrong with people and how to explore the reasons they bring the fatigue. So one thing that we have learned in all these years is that there's a lot of different mediators that are in interplay that balance each other that have to do with why people stay exhausted. So in most chronic diseases, this is the model. I use it for ME/CFS, but actually works for anything. Genetic predisposition, then something makes it happen, a trigger, and then a whole host of mediators keep it going. Immune system, endocrine system, more endocrine system, sleep, psychosocial, so on and so forth. All these things are playing a role that result in illness persistence. So most of the work we do in our research is with people who are already sick, right? So we mostly care about mediators. We mostly care about why do you stay that way. And we'd like to know, why did you get that way? But we really want to know how to get you out of that way. So most of my work has been in that mediator space. So when you break it down, these many contributions to fatigue include, like I said, body system, cells, the brain. Sleep can't underscore how important sleep is in having fatigue. Kind of dull, but it's amazing how many people think that 3 to 4 hours of sleep is enough to go on and then go through thousands of dollars worth of work to try to figure out why they're fatigued, when in fact they simply aren't sleeping enough. Pain, and then the medications, Your Honor, the nutraceuticals you take can contribute to fatigue. So just start at the beginning. Energy comes from your body making energy, and we mostly rely on something called aerobic energy, meaning that we need oxygen and glucose at a cellular level to make energy. So right away, it relies on your lungs. Excuse me. And not just your lungs, the ability of your heart to pump blood through the lungs to pick up that oxygen. And not just your heart, the ability of your body to make all those red blood cells to pick up the oxygen as it rolls through the lungs. So those are really important factors to having enough oxygen delivered to the tissue. And then there's a third thing that's really relevant to dysautonomia, and that's your microvasculature, the tiny little vessels, the threads of vessels that go to every millimeter of your tissue to deliver those red cells. And sometimes those clamp down because they're vessels and they cannot deliver the goods to the tiniest little distal tips of those vessels. and get enough oxygen to when you need it the most. And so getting oxygen is a really important thing. Now, there are some conditions that mess up the lungs, like asthma and COPD, pulmonary fibrosis, particularly post-COVID fibrosis, which we're seeing more and more of. But in dysautonomia, more often than not, it's vascular, meaning the vessels are in spasm from adrenaline, and they're not delivering enough oxygen to the very tips of the tissue. I mentioned the heart and the body systems of energy that have to do with delivering blood around. So I always say the heart is simple. It's pump, pipes, and wiring. Well, sort of, nothing simple. But it is a pump that squirts blood through pipes, the blood vessels, and it's wired with electricity, with the wiring from your brain that tells it what to do. And it's affected by your blood volume. Now, I'm going to say blood volume matters. We don't talk about it very much, but we've done studies in ME/CFS to show the average patient is a liter short. A liter, that's like almost a quarter of the blood volume short. And you're trying to get all that oxygen kicked around your body with 75% of the cells that you need to do it. So right away, you've got a problem, right? So blood volume is a much ignored, medically important and treatable space that can affect energy. The efficiency of the pump, I'm going to talk about that for a moment. And then getting the signals right. How is it wired? And many of you have experienced tachycardia, postural orthostatic tachycardia syndrome. There, you're beating like crazy, right? Your heart's going 120 times a minute. Well, between every beat, you need enough time for the heart to fill up so it can efficiently squirt that blood back out and deliver to the good. So if it gets too fast, it's increasingly less efficient and less able to push that the blood around effectively. And so the efficiency of the pump matters, and the muscle itself, whether it's strong enough or it's gotten too thick to allow the blood to get in. And then I already talked about the veins and the arteries and their ability to contract and dilate. But most of you with dysautonomia have looked down at your feet when you're standing up and said, oh my gosh, they're blue. Well, that's your veins very dilated. Right? They shouldn't be like that. They should be contracting enough to deliver the goods above your belly button. So the average dysautonomia patient, when you look at their volume of blood, you look at the bottom half of their body, and they have 70% of their blood volume below the belly button. And that's only 30% up here, like 1.5 liters of blood at best to take care of your lungs, your heart, your brain, a whole lot of space up here. And it's not enough. And it's all down there in those dilated vessels hanging out, not being very helpful. So when the doctors are saying compression hose and things that compress your veins, they're trying to deliver the volume of blood you need back to the heart so it can do its job and get that around to the tissue. So when we talk about autonomic dysfunction, see the blue feet there? I put it on the slide. The pink feet versus blue feet. That is basically autonomic dysfunction has so many names: postural orthostatic tachycardia, neuromediated hypotension, sympathetic overactivation syndrome, and they're all lumped together under this umbrella term autonomic dysfunction. And that's appropriate because some people have more than one of these diagnoses going on. So one cheap and easy way we do in our own clinic is everyone that walks through the clinic, every single patient has something called the NASA wing test. That's from NASA, the astronaut land, right? And they do this for the astronauts to see if their autonomic function is being affected by being in space. So when they come back from a mission, one of the first things that happens is they lean them up against the wall, just like this nice person on the wall here, for 10 minutes. And they take serial blood pressures and pulses and see what happens. So what should happen is you shouldn't have more than a 10 beat per minute change or a 10 millimeter drop in your blood pressure. But if you get a 30 beat change or a 30 beat drop, you meet the diagnostic criteria and do not need to go get tilt table. You can just go right ahead and call that person a dysautonomia patient with POTS or NMH, one of those diagnoses, depending on what you found. It's like, I call it the cheap tilt. And just like a tilt, you can't leave a patient leaning on the wall because patients get dizzy and fall down, they pass out. You have to be there for it. And so this is a test that in the clinic we train people to do correctly. And the patient, we can be getting their whole oral history while they're leaning on the wall, which is nice. Don't waste that time. But meanwhile, we're getting this nice measure that's super helpful in the clinic. So getting the signals right, dysautonomia, you know this, but I'm going to repeat it. You've already had effects on lectures today. But the autonomic nervous system wires everything that's important in your body. It wires your brain, it wires your heart, it wires your lungs, it wires your GI tract, it wires everything. And so it's no big surprise that people with dysautonomia have symptoms everywhere. And so it gets so confusing. You walk in your doctor's office and you have IBS, and you have gastric periparesis, and you have tachycardia and arrhythmia and this and that and the other thing. And the doctor's rolling their eyes for what's with this patient? When in fact they're just saying, hey, I have dysautonomia. That's what they're saying. So it's an important thing to say. And we often talk about, the balance, the sympathetic parasympathetic balance. And so when I stand from sitting, in 3 minutes, in the first 3 minutes, my sympathetic nervous system turns on and gives me more pulse, more contraction, pumps more blood back up to the heart. But within 3 minutes, I auto-correct and with the parasympathetic system, right? They do a little wobble and then I settle, right? But with that 10-minute lean test, what you see is people go into sympathetic or they go into parasympathetic and they don't correct. And now they're having a lot of symptoms. In 10 minutes into a lean test, they're not back in their original balance. So that's a regulatory problem. And there's a lot of different reasons that might happen. As you can see in this, that it's generally called the parasympathetic, the rest, relax, restore side, right? So you've got help you sleep better. So it's doing more of the quiet, gentle, meditative things, improve your parasympathetic state. You can breathe and increase your parasympathetic state. There's a lot of exercise you can do for parasympathetics. Sympathetic is adrenaline, go, 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 go. So in my veteran patients who are hypervigilant from, learning how to sleep with one eye open, they don't learn that. They never lose that trick, right? They stay hypervigilant. And so they stay in this hypersympathetic system, and it starts having terrible effects on their body because they are not parasympathetic. They're not digesting. They get a lot of constipation and symptoms, and they're hypervigilant. They're leaning into PTSD symptoms. Even if we're not that PTSD, sometimes there's a lot of symptoms there. And that's something that happens from having your seesaw get out of whack and keeping you in one state. So in one of the most common findings we find when we order echocardiograms in our patients is something called diastolic dysfunction. And if you look at this little picture of the heart beating, the top chambers are the atria, and then the bottom chambers are the ventricles. And normally they fill up the atria, and when they're full, the valve opens and drops it into the ventricle, and then the ventricle gets a good solid pump out, and you've got a nice blood flow through your lungs into your body, depending on the side of your heart. But if the atria doesn't have time to fill before it drops the blood into that ventricle, then you just don't have as much blood flow because you didn't get the volume into the ventricle. And this is a very, very common problem. This can happen for a lot of different reasons. Probably the most common reason I see for diastolic dysfunction is correctable is simple volume. Like the blood volume is low, there's a tachycardia that responds, not enough time between beats to fill. And the stretch receptors in the heart respond to the low volume by asking for more speed of the heart, more adrenaline. And it just vicious cycles the whole thing. So getting the blood volume into a normal state with simple things like salt and electrolytes and sometimes more things like cortisone and other kind of drugs that increase your blood volume can make this normal dynamic in the heart improve. But you can see in this side, on the far side, the diastolic dysfunction is important not to ignore. The doctor needs to know about it. Send you to a cardiologist if they don't know what to do about it. Because over time, that ventricle will work so hard, it will get a fat muscle, a hypertrophic muscle. And then it can't fill right. Now you have a change in the heart that's going to keep this going. And so it's something that you don't just, diastolic dysfunction, ha, ha, ha. It's not. It's actually a very important deal and it needs to be addressed. So implications for treatment in this pump and wiring thing is that you fill the space. There's ways to do that. You regulate the pump. Sometimes we slow it down when it's going too fast. Sometimes we speed it up when it's going too slow. You compress the vessels in the legs where things are pooling. And that's why compression, Aerobic, that kind of thing are so important. And gently recondition. I say gently because reconditioning can flatten our patients. ME/CFS patients cannot be sent off to physical therapy and say, do a cardiac rehab program. They will be flattened by that program. But doing the kind of program that has you doing little bits of aerobic exercise, just as much as you can tolerate, not enough to make you feel bad the next day, which is usually 2 or 3 minutes, 3 or 4 times a day. I usually say, put a recumbent bike in the middle of your living room and use it 2 or 3 minutes, 3 or 4 times a day, and get a little aerobic conditioning going there. Or do pedals in the air from the bed lying flat. There's a whole lot, a beautiful website in the Dysautonomia Association's webpage on how to do exercises safely when you're dysautonomic and the acetylene test. So moving along to mitochondria. Cellular energy matters, and mitochondria is the powerhouse of the cell. We learned that in high school, and it's still the same after I went through medical school. It didn't change one whit. But it becomes it's a very important space because in chronic fatiguing illnesses, sometimes the mitochondria power down. Now, mitochondria will power down if you just don't ask them for energy. So being really deconditioned affects the number of mitochondria you have, how efficient they are. So just the lack of exercise is enough to drag down energy production in a cell. But another thing that's very serious and can be easily addressed is oxidative stress. When mitochondria make energy, aerobic energy, they're using this thing called the Krebs cycle to making energy. And they throw off these things called free radicals that are toxic to the cell. And there's a whole other pathway, snags them up, recycles them, and puts them back into the energy thing. So it's this perfect little figure eight inside the cell, making energy, cleaning up the mess, making energy, cleaning up the mess. That's how it works. But if it gets ahead of itself, and there's free radicals that can't be cleaned up by the cell, they start tearing up the mitochondria's membranes, and they die. And then you don't have enough mitochondria in that cell. And eventually the cell itself will die. And so oxidative stress, again, another thing we go, oxidative stress. Well, oxidative stress is a big deal. And by the time you're 40, every healthy person is in a negative balance and is already suffering from oxidative stress. If you eat a really healthy diet, all kinds of greens and rainbows and all like that, you'll have a lot less of it. But still, just on age, you'll have oxidative stress. But if you are hypoperfusing, if you're not bringing oxygen to the cell, you're going to go into oxidative stress because there's a second pathway that cell uses when it doesn't have oxygen called the anaerobic pathway. And it makes way more free radicals than the aerobic pathway. It's much more destructive. And so it's very important to think about oxidative stress and eat the green rainbow diet, green, red, orange, all the things with antioxidants in it, but also seriously consider a healthy antioxidant supplement because it makes a difference. So free radicals, oxidative stress. Now, what about the brain? So a lot of that I just spoke about, the tricky thing that we sit around in clinic thinking about was, I just ordered a lot of antioxidants on this patient. Are they going to cross the blood-brain barrier? Are they going to get where I need them to go? And the answer is mostly not. And a lot of the antioxidants we most commonly get have a really hard time crossing and getting into the blood, into the brain. So glutathione, the body's most important antioxidant, is a terrible antioxidant for crossing the blood-brain barrier. But its precursor, N-acetylcysteine, NAC, NAC, gets across really well. And so there's been some beautiful studies now by Dr. Shungu at Cornell in ME/CFS showing that NAC, N-acetylcysteine, can reverse to normal the oxidative stress in the brain of an ME/CFS patient. So I use a lot of MAC now in our clinical practice, and the patients definitely can tell the difference. Now, this has been shown. We can actually do imaging now that looks at oxidative stress in the brain. That's pretty cool. That's new. So we can tell, and that's what Dr. Shungu did with this NAC study, before and after images of the brain using an antioxidant and seeing it across. Why does that matter to fatigue? Well, of course, the brain is where fatigue rests the most. That's the whole area of your brain that tells you if you're tired, if you have energy, if you have whatever. All that's going on in the brain. So I talked a bit about antioxidants. I talked a bit about mitochondria. One way to get your body to make more mitochondria is to use it. Using your body. Using your brain makes your brain make more mitochondria. Using your muscles makes your muscles make more mitochondria. And so this idea of using exercise during cognitive exercises, using your brain, that's really important. It probably plays a lot actually into neurodegeneration. That's why people who are deaf are more at risk because they're not using that part of their brain. They can't hear anymore. People who are not challenging their brain enough are at higher risk. People who are learning new things as they age have brain that's growing. But I know in ME/CFS, there's some studies that show the actual brain mass is shrinking, and it's the brain mass where the thinking goes on. So when I saw that, my patients were in a panic. I said, that is not neurodegeneration. That's not using your brain, and it's shrinking. So let's do that. Let's do something different. Let's try to challenge that brain and see if it can grow. And in fact, other people might argue that those studies and did in fact show that they could get brain growth with cognitive behavioral therapy and with teaching and that type of thing. So speaking more about cellular fatigue, I talked about mitochondria, but I didn't talk about how much each individual cell is affected by what it's swimming in, okay? Because the cells are bristling with receptors, and the receptors are telling the cells what to do. And they're swimming in the blood, and the blood has got all the hormones and cytokines and chemokines, and these are signalers. And this is where most of our research sits, is in this space where how's the body communicating across all these systems, and is it in a good balance? And the answer is no, it's not in a good balance. It's in a chronic sick balance. And so our work actually is all about whether or not you could reboot or change those balances back to a normal balance. So we spend a lot of time in this idea of complex interactions of systems and hormones, cytokines, immune regulation, neuropeptides from the brain, all very important. I should say neuropeptides from everywhere. Neuropeptides in the brain, the gut, they're everywhere. But they all are a player in these illnesses that are driven with the symptom of fatigue. So when you're talking about the brain, you're talking about the space in your body that thinks. We know that. The space in your body, the brainstem, that manages all the things that are in dysautonomia, like your pulse and your blood pressure and so on. That's within your brainstem. But this very central part of the brain where you have emotions and feelings and the sensation of fatigue or the sensation of energy, happiness, sadness, it's all in that same general area, this tiny little part of the brain. And they're regulated by the neuropeptides and the inflammatory symptoms that signals that are in the area. So when we're looking at our patients, the ME/CFS patients and the gulf-port illness patients and the long COVID patients, what do we see? Inflammation in the brain and oxidative stress. And they're playing off each other. And if you would imagine, I'm going to challenge the people in the room here, because this is an older technology, but there's something called a CB radio, the one that the truckers use. And it's got all this background noise, and they play around with it down so they can get a signal. But if you can imagine your brain as a radio signal, a bunch of signals going on, and if it's just a noisy, loud environment, how is the right signal supposed to get through to tell your brain to do the subtle little corrections that keep us going from minute to minute, second to second, making these adjustments? So this noisy, inflammatory, oxidative stress brain has a lot to do with why the hormones are just subtly off, why the other neuropeptides are just subtly off, or sometimes big time off. But our idea in our research and in our clinical care has been, let's fix the things we can fix. We can fix oxidative stress, check. We can fix inflammation, check. And then see who's left. And you have someone who's a whole lot healthier when you take care of the brain and take care of these the background noise, if you would, of oxidative stress and inflammation. And hopefully you're also reducing the risk for for more serious consequences like neurodegenerative disease down the road. And the other thing that's going on in the brain is all the regulation of sleep. And that is a big deal because sleep has stages. In fact, saying it has 3 stages. And sorry, the language changes with time. But the very most superficial stage is that when you're not quite asleep or just barely asleep and you can hear everything in the room, that hypervigilant sleep, that is not restorative. And yet that is the sleep patients with fibromyalgia are trapped in. That is the sleep that PTSD patients are trapped in. And many, many, many of our patients that have these other illnesses are trapped in this alpha wave sleep. So if we can get them down into a deeper stage of sleep, you'll see more restorative sleep and you'll see a healthier patient. So we deal a lot with inflammation. We deal a lot with inflammation in the brain, in our care. And we have a lot of reasons too. There's a lot of good science to prove that the inflammation. There was some images of a PET scan from 2014 that has since been validated by every group that's looked in the ME/CFS population, that there's sort of scattered areas of inflammation all throughout the brain. And we know, as I said, that the hormones themselves are dysregulated. And they're dysregulated particularly in 2 areas: the adrenal gland, which is also regulating your blood volume, and your stress hormones, cortisol, your anti-inflammatory hormones. And it's dysregulated in your gonadal hormones, estrogen and testosterone. And these are really important players and areas that we can measure and treat. And so these are areas that in our models of how we should ideally reboot the system back towards normal, we have to pay a lot of attention to it in our research models, because when we look at inflammation, oxidative stress, hormone balance, it turns out that we're using cocktails of approaches that are dealing with all of those different areas in order to envision in our computerized models of how to make people better, that we have to fix 3 buttons to actually make the difference. We can't just focus on one thing. I'm going to mention one cell because it's an under-discussed cell, but it's called the mast cell. And when people have blood volume problems and dysautonomia, if they have mast cell activation, they're going to trigger a lot, because mast cells make mediators that vasodilate, that make the vessels leak, that do a lot of different things. And in ME/CFS and among COVID, mast cells are major players in the inflammatory side. And we're blessed at NOVA to have Dr. Theo Herrerides on our faculty. He's amazing. He's the #1 mast cell expert on the planet. And he's in our group, our group, and he teaches us so much. I've been so lucky when he joined our group, because we all feel like we're mast cell wizards now. And there are things you can do to prevent mast cell activation, and some of them are simple nutraceuticals. So trying to keep mast cells quiet by stabilizing their membranes. The most powerful thing is steroids, but who wants to be on steroids? So you back up into nutraceuticals like luteolin and quercetin. And antihistamines that mop up the mediators that get dripped out. And these are important players. Now you think that mast cells are going to be anaphylaxis, I'm going to drop down and then I'm going to swell up. But in fact, mast cells can cause a lot of miserable disease just by leaking a little bit all the time and just leaking these nasty mediators that they have. So taking care of them to try to reduce inflammation and all the vasodilation and things that are happening in your arterioles because of mast cells, that's a good target for treatment. Another treatment that we use is low-dose Naltrexone. This is not FDA approved, so I have to say that. I'm talking to you guys, but Naltrexone itself, the drug that we're diluting, is approved, and it's approved at a very high dose at 100 milligrams. And the studies that have done with low-dose Naltrexone, the dose is 1 to 5 milligrams, much, much lower dose. And what it's doing is something very different than it does at that high dose. At that high dose, it's blocking opioids, and it's used to treat people with narcotic addictions or to reverse someone who's had an overdose. But in these low doses, it's quieting inflammation in the brain, and it does a good job of it, and it does it very safely. And so we rely very heavily on this as our one of our key players that we use for brain inflammation. The other one we often use is human and herbal, but one that is either liposomal or nano-human circuits across the blood-brain barrier. The other thing I talked about being fatiguing, I'm sorry, this is more about naltrexone. If you get naltrexone, you shouldn't be on opiates. And sometimes it increases your dream state, which is generally healthy, it's restorative. But if you're PTSD, it can give you nightmares, and then it's not so good. So 15% of people get increased dreaming. So I always warn people. And if they have trouble with it, use it in the morning instead of. So where I was going with this. Okay, pain is another common cause of poor sleep, and then fatigue because of pain. So the fibromyalgia patients are the best patients to describe this in. We use low-dose naltrexone as our number one treatment for fibromyalgia. And we'll lean into these FDA-approved fibromyalgia drugs, which reach different other mechanisms to treat the pain. Notice that none of these are opioids. These are all drugs that change neuropeptides in the brain. That's a fibromyalgia diagram of all the places that the doctors poke on to make you hurt to prove you have fibromyalgia. Now, fibromyalgia has changed a lot. In the last 10 years, there's been work to show that it's more likely than not an autoimmune disease. Small fibers, the nerve endings, the sensory nerve endings called small fiber neuropathy. There are clinical trials now going on with IV gamma globulin, and they're looking very promising. So it may be one of those diseases that has a treatment that's going to be highly effective now that we know the cause. And I talked a little bit about sleep already. So in talking about sleep for a moment, I'm going to say there's a lot of things about sleep. I know dysautonomia patients hate me to say this, but you should use your bed to go to sleep in, okay? Because if you're resting in it all day, the Pavlovian response you have when you go to bed to fall asleep is just ruined. It's better to lay up sorry on the couch than to lay up sorry in your bed, because your bed should be something you condition yourself to fall asleep in. So you should avoid that. You should have a bedtime that's the same bedtime all the time. There are some sleeping pills that actually trap you in 4 stages of sleep. It's called doxepin and valium drugs, and there's some that don't. And so it's important when your doctor's prescribing these things to understand that you don't want to trap a fibromyalgia patient or chronic pain patient into alcohol sleep. We'll say you don't use some of their classic, most commonly used sleeping pills. But instead of being in the antihistamines and tricyclics and some of the more sedating other medications that aren't necessarily sleeping pill, classic sleeping pills. And sleep studies, that's really important. I did a study in my own population that I sent to sleep studies, and we saw sleep apnea way more often than we expected to, and it was not predicted by being short with a short neck or overweight. Tall, long, skinny people with long necks had sleep apnea. So anyone that says, I can't, when I wake up, I'm exhausted, sleep study, everyone. If they have non-restorative sleep study, make sure you're not dealing with something that's totally treatable and very dangerous to ignore. Emotional fatigue, I'm not spending any time on it except to tell you it's a real thing. And a lot of patients that we experience a lot of hopelessness and sadness because they're so sick, and they have perhaps exhaustion in part because they're depressed, and that's real and it's treatable and it should not be ignored. It's very dangerous. And people blow off people's depression all the time, like, oh, buck up. You can't buck yourself up out of depression. You have to actually do something about your depression and go seek professional help. I will also say every primary care doctor now prescribes antidepressants, but psychiatrists are the experts. They actually know a lot more than I do, and all my primary care friends do. They actually train to treat this for years and years, and they're good at it. So don't be embarrassed to go see a psychiatrist if you need help with a mood-related problem, and it's perfectly okay. There's biologic reasons to have depression, all those neuropeptides I talked about. And then there's just, I'm so tired of being tired. I'm exhausted. I can't do it anymore. So what I want to end this lecture on is hope. if you should never feel hopeless in an area where we're making rapid advances in research and we're translating it to new interventions and new types of things that we can do. So I know I'm running out of time. I wanted to mention there's things you can do that aren't drugs, like manipulative medicine, the osteopathic way of treating a lot of different kinds of chronic pain conditions. Acupuncture, very helpful. Yoga and gentle stretching. A lot of people have Ehlers-Danlos syndrome. We can't overstretch, but you can stretch within your limits. Using antioxidants and mast cell stabilizers, like I mentioned, are very helpful. And there's some nutritional interventions you got to be careful of, particularly licorice root. Be very careful. A lot of people with dysautonomia take it because it's the thing we make fluoride from. It causes you to retain fluid, which is something good. But it causes you to retain fluid because you're sucking up salt and spitting out potassium. And if your potassium goes too low, you're in a lot of trouble. So, and it feels like fatigue before your heart stops. So you really won't notice the symptom since you're so fatigued that your potassium's dropping. And then you're in more trouble because you're getting into very serious arrhythmias if your potassium gets low. So I really argue against licorice root as a nutritional intervention unless you're getting your bloods checked. And then, okay. But if you're not checking your potassium, don't do that. Another one is overhydration. A lot of people are drinking gallons of water, and literally gallons. And that's crazy because your poor little kidney can't do that. It rinses out the entire system that causes you to concentrate urine. And now you're diuresing, you're getting even drier because your kidney can't hold back the fluid anymore. It doesn't have the way to do it. So don't overdo the fluids. All right, time aside. We're doing a lot of cool science. We're making tremendous headway. Again, ending on the hope. The hope is the most important thing we're doing here. This concept that we might be able to reboot the systems back into a normal balance. It's very exciting. But we also have a lot of clinical experience. And these are the things that affect people a lot when we identify them. If you're in a moldy environment, you're constantly exposed to toxins, particularly mycotoxins, you could be poisoning your cells, and that could be a big problem. Don't do that. Okay, so that's a really important thing. South Florida, it's a huge deal. And then, as I said, working within your energy envelope, not exhausting yourself when you're beating yourself up to get better to the point where you're exhausting yourself trying to do things you can't and shouldn't be doing. Those are probably the two take-home messages. Pace and make sure you're not eating or living in a toxic environment, emotionally, physically, or biologically. So we'll end up with finding new inventions down these paths. These are really important points that we're working on, our group and many others. And we're doing these homeostatic reboot experiments to try to move it to clinical care. In Gulf illness, we're already in phase 1 studies doing this. And in cardiac syndrome, we start our first phase 1 in the summer. So it's exciting. Yes. This is a curative concept. It's a moonshot, that if we can cure people in the computer model. And the animal model for before we cured the animals. So that was exciting. And we moved to human based on the animal model. And ME/CFS, there's no animal model, so we're just moving to human. But we're using safe and repurposed drugs, so it should be okay. So, we've learned a lot. I've shared a lot. We hope to learn a lot more. How's that? I'll take your questions. Thank you.
I'm just curious with all the research, if you are recruiting patients for studies.
Absolutely. So we have 3 focused illnesses in our group. We do ME/CFS, long COVID, and military toxic injuries. So our research sort of circles around those groups. But we're recruiting in all those areas. We have about 18 different clinical trials going on. If you go to our webpage, you can see a lot more about what we're doing. So /NIM. So NSU/nova.edu/NIM.
NIM. Okay. Now, here's another question right here. Use the website one more time.
It's nova.edu/N is in Nancy or neuro, I is in immune, and M is in medicine, neuroimmunology.
All
You're
right.
the Institute for Neuroimmune Meds
Yeah.
at Nova University.
So how often do you see autonomic disorders in what category is it? In your CSF population? How often do you see
Almost
that?
always.
Almost
Almost
always.
It's actually part of the case definition. The person has to have fatigue that's moderately to severe, and either cognitive complaints and or dysautonomia. So it's part of the case definition.
Okay. Any other questions? We have another one right here. Still around?
If a sleep study is something that we should all be participating in, essentially if we're fatigued, is there anything specific that we need to be asking the tech or telling them to help make sure we get the appropriate diagnosis?
Yeah, and there's three different things that they look at when they do a sleep study. They look at whether your brain is telling your lungs to breathe correctly. That's the rarest form of a sleep problem, but it happens. It looks at whether or not your throat closes so much it actually stops your breathing. That's sleep apnea, right? And then how many times a minute that happens or an hour that happens makes the diagnosis. But there's something that they don't watch close enough. It's called upper airway resistance. It's when your throat almost closes. And you can understand you're fatigued, right? If you do anything for very long, you feel that the fatigue, even holding your eyes open, sometimes it's fatiguing. But can you imagine all night long trying to keep your airway up? So a lot of patients have this upper airway resistance, and they're really helped with CPAP, with positive pressure. It keeps their airways open all night long.
Okay, great. Any more? All right. Dr. Klimas, thank you so much. So on our side now, you can get out of the little box and go back to your normal doctorate. So thank you so much for your time. We appreciate it.
I wanted to do the mind thing. I wanted to bring a beret. I was going to wear a beret.
Doctor, thank you again so much. We appreciate it.